patients with ARDS. These are my disclosures. Well, basically, the idea of the open lung approach is that for patients with ARDS who, in general, they have those patients have a decreased functional lung size and have a significant proportion of their lungs collapsed with atelectasis. Those patients are at increased risk for lung injury, both because of overdistension, but also because of cyclic opening and closing of lung units. So the idea to offer the open lung approach is that after one uses recruitment maneuvers, that is, we transiently increase the transpulmonary pressure to reopen lung units. And after that, we keep the PEEP at levels high enough that we maintain those recruited lung units open. We can protect the patients from atelectrauma, the cyclic opening and closing of lung units, and perhaps avoid overdistension by having a more homogeneous lung. So these are some of the potential benefits of lung recruitment maneuvers and the open lung approach: to open the atelectatic areas, to reduce lung homogeneity, to improve lung homogeneity, and therefore increase oxygenation on one side, and on the other side, by increasing lung compliance, we might decrease driving pressure, decrease mechanical power, and therefore we expect to decrease ventilator-induced lung injury. On the other hand, lung recruitment maneuvers don't come without their hazards. They may, in fact, during the recruitment maneuver, we subject the lungs to extraordinarily high pressures. So during the recruitment maneuvers, we may actually cause ventilator-induced lung injury. We may overdistend the rated areas. If we don't if we don't recruit consolidated areas, this problem may be even higher. There is the risk of barotrauma and also hemodynamic consequences of recruitment maneuver, for example, to increase pulmonary vascular resistance and to decrease cardiac output. So we have conducted a randomized control trial part where we included 1,013 patients with moderate to severe ARDS. It's important to highlight that those patients, before being enrolled, they needed to be ventilated for at least 3 hours under a standardized mechanical ventilator protocol. We used the ARDS NET protocol with low PEEP and low tidal volume. And we collected blood gases at standardized PEEP and FiO2. So from the initial, about 40% of the patients that had moderate to severe ARDS were actually enrolled, because many patients after this period, their PF ratio increased to more than 200 and are not enrolled. So it's important to highlight that the results of our study, they may not necessarily be applied to all patients with moderate to severe ARDS, but to those that maintained low PF ratio after this standardized ventilation protocol. And half of the patients randomized to the lung recruitment maneuver and titrated PEEP protocol. Half of the patients randomized to the low PEEP strategy without recruitment maneuver. This was basically the recruitment maneuver and the PEEP titration scheme. We started with a PEEP of 25 for 1 minute. ventilating patients under pressure-controlled ventilation with a pressure above PEEP of 15 for 1 minute. Then we increased PEEP to 30 for 1 minute and 35 1 more minute, reaching a maximum pressure of 15. After that 3 minutes recruitment maneuver, we started titrating PEEP with a decremental PEEP trial, starting with a PEEP of 23. After 3 minutes, measuring static compliance of the respiratory system, and then decreasing PEEP in steps of 3. After each 3 minutes, measuring static compliance, the people associated with the best static compliance, plus 2 centimeters of water, was the ideal PEEP. After PEEP titration, new recruitment maneuver, 35 of PEEP, 1 minute, and then maintenance ventilation with the optimal PEEP for at least 24 hours. These are the baseline characteristics of the patients. Basically, I would like to highlight that those were sick patients with high SEPS3 scores, more than 2 non-pulmonary organ failures per patient on average, and 2/3 of them with septic shock. The results surprised us. Of course, our hypothesis was that we might offer benefit to the patients, but instead we find increased mortality for patients assigned to the lung recruitment and titrated PEEP strategy as compared to the low PEEP strategy. Hazard ratio was 1.20, it was significant. The same for 6 months mortality. We have found also that we have increased the risk for adverse events, both in the lung-related adverse events. For example, barotrauma increased from 1.6 in the control group to 5.6 in the lung recruitment and titrated PEEP group. And we had increased problems in hemodynamic problems. There was an increased need to use vasopressors or to increase the dose of vasopressors within an hour in the experimental group compared to the control group. I think it's important that in order to understand the results of our study, to explain that we thought a lot and we cared a lot in terms of making sure the implementation of the trial was adequate. So we have trained all sites in loco before enrolling the first patients. That except for on site outside Brazil in Malaysia, we trained with web conference, and training visits were quite often repeated. In the site, we had annual investigators meetings. We had formal teleconference 2 times a year. We communicated by WhatsApp with the sites after every patient randomized, sending reminders of the protocol assigned. We had a bedside manual of operations, which was very easy to be followed. The idea was that even colleagues that were, say, on the night shifts or on the weekends could understand what was supposed to be done to the patients for the regular things and for the management of non-normal situations too. And we have a phone line available 24/7. So this is just a picture of one of those meetings and the manual. We think adherence to the protocol was nice. For example, this is reflected in the very nice adherence to the low tidal volume, which was under 6 ml per kilo of predicted body weight, both in the experimental and control group along the days. So after having considered these results, we think I think the question here is why did we have this? Did we have these results? Why did the open lung approach did not help ARDS patients? And I think there may be some possible arguments here, some possible explanation. One is that very high PEEPs are needed to prevent alveolar cycling. So this is one possible consideration here is that if we consider that the area, the proportion of the lung, which is submitted to cyclic opening and closing, is represented here in light blue. When we increase the PEEP from, say, 5 centimeters of water to 15 centimeters of water, that is values that we ordinarily use in clinical practice, we don't really remove cyclic opening and closing, but instead we just change the zone of the lung where this phenomena is occurring to a more dependent zone, and possibly add overdistension to the anterior areas. Another explanation is that we may, at least during the recruitment maneuver, increase biotrauma, as was suggested by these animal studies, where they found increased cytokines in the alveolar lavage of the animals after recruiting maneuvers compared to the control groups. Another possible explanation is that initial clinical evidence was not complete, or not completely reliable. For example, some studies suggested that lung recruitment for the patients some studies suggested recruitment was very good. That is, most of the lung of those patients with ARDS could be recruited. Some of the other studies were contradictory. For example, this study by Gattinoni and collaborators suggests that on average, the mean proportion of the lung that could be recruited in ARDS patients was low, 13%. Of course, with high variability, some patients have appreciable recruitment, but on average, most patients don't. And of course, if you offer a recruitment maneuver for a patient who does not respond to it, it possibly cannot be helpful, but only add adverse events. In fact, what we found in our study was that in this figure here, we are representing the change in static compliance of the respiratory system after recruitment maneuver and titrated PEEP. And you can see that on average, static compliance changed very little. It was on average 3 mLs per centimeters of water higher. With a high variability, some patients recruited, some patients had nice improvements in compliance, but on average, it was small, and it was reflected on a very small decrease in drive pressure. That is, we aimed to decrease driving pressure by after recruitment maneuver and offering protection against the bili by this mechanism, but in fact the decrease in driving pressure was too low, and perhaps the price that the patients paid during the maneuver was higher than the benefit. Other thing to consider is that some studies have been conducted before ours suggesting benefit on mortality. This is represented here in this meta-analysis, but one can see that most of those studies suggesting benefit on mortality were at higher risk of bias, whereas the studies at lower risk of bias are more neutral and with a non-significant benefit. Very recently, we have this meta-analysis published in Intensive Care Medicine, and after ART, you can see that more studies have been published, and totalizing more than 3,000 patients with ARDS recruited in lung recruitment trials, and you can see that the effect of the lung recruitment maneuvers on mortality is converging towards one with a non-significant effect. So the cumulative evidence suggests that there is no benefit in terms of mortality for the overall ARDS patient. There was a decrease there was improvement in hypoxemia. There was also an improvement in terms of less need of rescue maneuvers, for example, ECMO, but at the cost of more hemodynamic compromise in recruited than non-recruited patients. And barotrauma was not different among groups, but confidence intervals are very wide, imprecise, and so this estimate of effect on barotrauma is not very reliable. One can question whether we have used the best recruitment maneuver, whether we have used the best deep titration method. There are other methods. I'm not going to discuss those now because of the time. But I would like to end this presentation by emphasizing something that I believe explains a lot of the lack of benefit of recruitment maneuvers in our study and in others, which is heterogeneity of treatment effects. The problem is that the syndrome ARDS is in fact represents several different types of problems, of pathologies. When one thinks in ARDS, probably we think in terms of pathology, we immediately think or tend to think in diffuse alveolar damage, in terms of increased permeability, but this pathologic correlate is found in only about 45% of patients with ARDS at autopsy. Many patients with ARDS don't, or more than half, don't have this pathologic problem. So it's very likely that those patients respond very differently, for example, to recruitment maneuvers. We have done a reanalysis of our study and classified them in clusters. Cluster 1 was of the patients with pneumonia and hypotension, vasopressor, and we have found that basically the detrimental effects of recruitment maneuvers was restricted to these patients in blue here in the curve, which are those patients in cluster 1 with pneumonia and shock, whereas the other patients without pneumonia or without shock had a more neutral effect or perhaps even a beneficial effect. So ARDS is very heterogeneous, and probably the treatment effects explain a lot of variability, and in the case of ART, in the final negative results of the trial. Very recently, the LIFE study compared a personalized strategy. In the experimental group, the investigators, they offered recruitment maneuvers only for patients with diffuse ARDS and not in the patients with localized ARDS, with focal ARDS. Global results were neutral, but one can see that the patients that were physicians classified a lot of patients erroneously. And one can see that the patients who had a higher mortality were those who were incorrectly classified as non-focal ARDS, but indeed they had focal. Those patients that had focal ARDS and were recruited had a higher mortality. So to conclude, the effect of open-lung approaches on clinical outcomes is heterogeneous. Open-lung approach do not improve mortality in general patients with ARDS, and it in fact may cause harm, particularly to patients with focal ARDS. Recruitment maneuver plus titrated PEEP should not be used routinely. Patients with moderate to severe ARDS, although they may have a role for patients with refractory hypoxemia, which are the minority of ARDS patients. But there is still room for research assessing the effect of open-lung approaches on subphenotypes of ARDS, for example, non-focal ARDS. Thank you.
Okay, thank you, Dr. Cavalcanti, for this interesting presentation. I think Professor Guerin is now online.
Yeah.
And I'm very pleased to welcome him and to introduce him, Professor Guerin from France. We talk about airway closure in ARDS, and please, Professor, you have the floor.
Okay, thank you very much, and good afternoon, ladies and gentlemen. I would like to thank, first of all, the organizing committee for the invitation to this meeting and to talk about airway closure in ARDS, a topic which actually has received overall little attention, but we have recent data that draw our attention more carefully to this finding. But before going through, I would like just to do a very brief recall about the assessment of airway closure during mechanical ventilation. But first of all, just a very brief reminding about the organization of airways in human lung. You have here two categories of airways. First, proximal airways, which are large.
Professor.
Represent. Yeah.
Hi, Professor. I'm Paulo speaking. Are you sharing your screen?
Sorry?
Are you sharing your screen?
Oh, sorry, maybe not. Maybe not. Do you? Okay.
I think you have to. Yes, I think you are sharing your screen and you have to open your PowerPoint, please.
What can I do that, to share the screen?
For sharing the screen, you have to press or to mark. No, yet. Do the same, please.
Sorry, I don't get you.
Do you see?
Do you have it?
Do you see a circle at the bottom of your screen that has a computer inside? You have to press this. At the bottom of your screen, Professor.
Yes, but everything seems, share your screen. Okay, maybe it's that. Is it okay?
Yeah. Please put your presentation, and
okay.
I wonder if you could start again, please.
That's okay.
Okay.
You see my slide?
Yes, perfect, Professor. Thank you very much.
Okay, sorry. So I'm very happy to discuss about airway closure, a topic which has received little attention, but we have no recent data that are going to redraw our attention to this potentially very important finding. First of all, I would like to make a very brief reminding about the assessment of airway closure in humans. Here you have a very known representation of the airway trees in humans. You have two kinds of airways, proximal airways, which are large, represent 80% of the airway resistance. The flow propagates through a turbulent mechanism. There is no gas exchange there, and the mechanism by which the air is going to flow there is a conduction. By contrast, you have here the second category of airways, distal airways, which are smaller, represent 80% of the airway resistance. The flow propagates through a laminar mechanism. It contributes to gas exchange, and the mechanism for the propagation of airflow is diffusion. So at any location of this organization, the airways can close through two mechanisms. The first is a volume-related mechanism through which the airways can close, even in normal young humans. But at very low lung volume, in independent lung regions, when you are below FRC, during expiration, airway may close. And there are three consequences of that. The first is the trapping of airway upstream the distal alveoli. There is a closing volume and a closing capacity which is going to happen. And you can see that from this parameter. You have here the TLC, the expiration is down here, and you have the point at which the airway closer can begin. And here you have the closing volume and the closing capacity. And the third consequence of that is the increase in airway resistance. And you know probably very well this relationship between airway resistance and lung volume. And you see that you have a nonlinear increase in airway resistance, which a maximal value when you are going to reach the residual volume. And one of mechanisms for this relationship is related to the airway closure. With increasing age, the small airway closure can occur at higher lung volume, I mean above FRC, and it is due to a loss of elastic recall with aging, making the pleural pressure less negative and hence the transpulmonary pressure less positive, making the airway prone to close. And this mechanism is enhanced in obesity. The second mechanism is a flow-related mechanism for the airways to close. And it is also called dynamic compression of the airways or airway collapse. And it is a cardinal feature in COPD. And look at what happens in these two parts of this graph. Here, we are at the end of expiration, and we have a transpulmonary pressure of 8 centimeters of water, and we are going to ask the people to make a forced expiration. And then to the 8 centimeters of water transpulmonary pressure, you are going to add 30 centimeters of water of pleural pressure due to the active effort to exhale. And you see that with the progressive reduction in the intramural airway pressure, there is some point at which the transpulmonary pressure became negative, and there is a closure. And this phenomenon is also named expiratory flow limitation. And you have here the expiratory flow against the pleural pressure, or the transpulmonary pressure, if you will, in a normal subject and in a patient with a flow limitation. And you see that in normal patients, you have some airflow limitations. That means that at some value of pleural pressure, there is no longer increase in expiratory flow with a further increase in pressure. But in patients with a flow limitation, like COPD patients, you see that this plateau appears very earlier at lower pressure. And furthermore, the slope of this relationship is lower, and this slope is a conductance, which is the inverse of the resistance. That means that there is higher resistance in patients with airflow limitation as compared to those who are not flow, as compared to normal subjects who are, however, exhibit expiratory flow limitation. So how can we assess airway closure or expiratory flow limitation during mechanical ventilation? So we have different techniques. First, a very interesting technique was developed by Kutsuko and co-workers many years ago. There is one, at that time, one prototype of ventilator was able to generate a negative expiratory pressure in the ventilator circuit, and therefore, at the very beginning of the expiration, you have a negative pressure at the time of the onset of expiration. And the response to flow from this increase in expiratory driving pressure should be an increase in flow, which is the case in this patient, which was qualified as not flow limited. However, in these patients, you see that here you have the increase in expiratory driving pressure after application of this negative pressure. You have an increase in flow, and then the two flows, the baseline flow and the experimental flow, I will say, are the same. And it was thought that those patients is flow limited over 35% of the tidal volume. Another technique which came out recently is a relook at the inspiratory PV curve of the respiratory system when the respiratory system is inflated at very low flow from the ventilator. Here you have the volume, and here you have the pressure on the x-axis, and the red line here correspond to the compliance of the ventilator tubing. And in blue, you have what happens to the patient. And you see that up to that point, the two lines, the blue and the red, are superimposed, meaning that from 0 to almost 15 centimeters of pressure into the airways, there is no change in lung volume. You are just inflating the ventilator tubing. And then you have a sudden increase in volume, and with a linear increase in volume with a further increase in pressure once you have overwhelmed this value here. And this was named the critical airway opening pressure, AEOP. And recently, it has been shown that a pattern like AEOP can be associated with a closure of a proximal airways, as demonstrated here during expiration by using a fiber optic bronchoscopy. It is only a case report recently published in Intensive Care Medicine. And finally, another method to assess airway closure or expiratory flow limitation could be lung imaging. But for that, we have to use a high resolution lung imaging to locate the closure of the airways if you want to assess the proximal or the distal location of the airway closure. And for that, to date, strictly speaking, we are only one method, which is a synchrotron image. And in Grenoble, in France, we have this facility, and Broche and co-workers with Sam Baya performed these studies in animals, non-injured and whose lungs were injured. And you see that they were able, to map the airways at different sites, and they were able to demonstrate here a proximal closure or a distal closure or a closure at both locations. And you can also see the airway trapping, upstream the location of the airway closure. So I would like now to move and to conclude with different recent study done in this field. And I come back to this study by Chen and co-workers. You have already seen this picture, and this study was done actually in 30 ARDS patients, and 8 of them, almost 1/4 of them, had this airway closure pattern. And you have seen, you can see here, the range of airway opening pressure between 5 to 20 centimeters of water from patient to patient. And some years ago, but also by using PV curve, Antoine Gaillard-Barraud also shown same finding. In another study, which is a secondary analysis of a previously published paper, Coudroy and co-workers found that the prevalence of airway closure, I mean the prevalence of airway opening pressure pattern, was 48%, and interestingly, they correlated the presence of this pattern to different molecules measured in the bronchoalveolar lavage. And you see that there was a significant, even so weak correlation, but significant statistically speaking, between AOP and the concentration into the BAL of the secretory phospholipase A2, which is a marker of surfactant depletion. Expiratory flow limitation was measured by using the NEP technique by Kutsuku in the seminal study done many years ago, and they found that 8 patients in 10 were flow limited on ZEEP. At that time, we were allowed, to ventilate ARDS patient on ZEEP, which is not the case now. And in a further study among of the same group, but in all comers patients with acute hypoxemic respiratory failure, almost 30% of the patients were flow limited according to the same technique. And in a second study, Kutsuko and co-workers studied the effect of PEEP, and they confirmed a high rate of prevalence of flow limitation on ZEEP, more than 50%. And interestingly, the response to PEEP was not the same between not flow limited and flow limited patients. In particular, in those patients who were not flow limited, the recruited volume due to the PEEP was higher, and the correlation between PO2 and recruited lung volume was very much better as compared to those patients who are not flow limited. But now the NEP technique is no longer available because it is not allowed to have a negative pressure into the ventilator circuit. Therefore, other methods can be used, and like atmospheric method, which are based on the same rationale, you are going to increase the expiratory driving pressure and to look at what happens to the expiratory flow response. And this is what we did in 65 patients with ERDS. We used the atmospheric method, in which actually we disconnected the patient from the ventilator at peak 5 at the very onset of the expiration, and we draw the volume pressure curve, and you see that we obtain exactly the same two kinds of profile as with the NEP technique, but we did that at peak 5, and you see you have here this patient who was not flow limited, even though this one was flow limited, no increase in flow in response to an increase in expiratory driving pressure. And interestingly enough, in our patients, so 20% of them were flow limited at peak 5, they had a body mass index significantly higher than patient not flow limited. The rate of a COPD patient was lower, even so not statistically significant due to the low number of patients, but there was only one COPD patient in EFL patients, and 11 of COPD patients were in the NFL group. And interestingly also, the intrinsic PEEP, the total PEEP, and the intrinsic PEEP here were significantly higher in EFL group as compared to the not flow limited for a similar respiratory rate. And when we confronted to the flow volume curve, the pressure volume curve, we had this very nice, confrontation. In patients without flow limitations, there is no airway opening pressure pattern. I mean, everything from PEEP 5 was open for the ventilation. Whilst in patients, and that was the case for the 13 ones, in a patient with flow limitation, there is this typical pattern of airway opening pressure. That means that up to PEEP 18 centimeters of water, there is no change in non-volume. And then you have this critical airway opening pressure that occurs after this threshold. And finally, but we didn't put too much emphasis on that, but the mortality was 3 times higher at the time of ICU discharge in patients with flow limitation as compared to those who were not. And there is some important impact, I mean in terms of physiological point of view, regarding the airway closure observation on driving pressure and compliance measurement. If you have here a patient with a typical pattern of airway opening pressure, and here you have the driving pressure not corrected for airway opening pressure, which is from PEEP 5 to the end of inspiration. And by contrast, if you take into account the airway opening pressure, you have the, I would say, effective driving pressure corrected for the airway opening pressure. And you can see that if you don't take into account this AOP, you are going to underestimate both the driving pressure and the compliance. And this has implication when you use the compliance or the driving pressure to set the ventilator. There is here on this slide, which is very close to my conclusion, about the anticipated mechanism for airway closure expiratory flow limitation. We have seen the importance of the low lung volume, and ARDS is characterized by a loss of aeration. The loss of surfactant is suggested by the study I mentioned before. Bronchoconstriction also can play a role, and there is a secretion of inflammatory mediator which may act on the bronchomotricity. There is also a role for the bronchial walls congestion, and also a role for compression from lung weight. But there are some need for further study to assess the role of collateral ventilation, the resistance of closure, which is an intrinsic properties of airways, and the role also of the chest wall. And finally, to conclude, airway closure expiratory flow limitation are frequent in ARDS patients. They had implications for the measurement of driving pressure and compliance. Also, an implication for the atelectroma in PIP selection, and it could be that there is an ERDS subphenotype with a different response to PIP and a different mortality as compared to patients not flow limited. But we need more data for confirmation of those findings, for a standardization of the measurement method, and also to better locate the proximal or the distal or both sides of closure with appropriate lung imaging. I thank you very much for your attention and again for the invitation.
Thank you very much, Professor Guérin, for this nice talk. And I think we should move on to the next speaker, and then we will have time for some questions at the end. So the next speaker is Dr. Morales from Spain, and he will give a talk about the effect of dead space in ARDS. Please, Dr. Morales.
Okay, I would like to share my screen, but I think that Professor Guérin is still on.
Oh, sorry. Okay.
Okay.
I'm there.
Entire screen. Did you see my screen? Hello?
Yes, you can start with your screen.
Okay, you see, okay. So, good afternoon. I would like to thank the organizers for inviting me for this prestigious meeting and for giving me the opportunity to dead space, pulmonary dead space, measuring it, and finally my conclusions. So, we all know that classic physiological abnormality in ARDS is hypoxemia. This chest X-ray showed in the left side show that bilateral airspace opacities, and on the right side a histological picture of a patient with, that succumbed with the ARDS with a classical hyaline membranes that shows alveolar filling and some degree of atelectasis that results in low VQ and frank intrapulmonary shunting. But we know from the ARDS network and other clinical trials that baseline metered ventilation is twice normal in patients with early ARDS, and the question is why? Reason that maybe is either a marked increase in carbon dioxide production or an increase in alveolar dead space. This diagram illustrates how dead space occurs implicitly in the lung. As you can see here on the left side, how a normal unit is ventilated with a normal blood flow, as compared to the right side, where a ventilated unit has no blood flow, generating a high VQ and thus alveolar dead space. Actually, colleagues almost 20 years ago published in this seminal article in the New England Journal of Medicine that how high pulmonary dead space is associated with increased risk of death in ARDS patients. They showed that it was independently high VT, and dead space fraction was an increased risk for death. In this multivariate analysis, pulmonary dead space was an independent predictor for mortality with the highest odds ratio. Looking at the data on this figure, you can see that the early elevation of ARDS fraction, ARDS patients compared to controls, and in the right side of the slide, it was significantly increased in patients that didn't survive from ARDS compared to survivors. And when breaking down the data, according to dead space fractions, taking increments as shown in this figure, with mortality in the y-axis and VT separated in quintils in the y-axis, having a dead space from 0.57 to 0.61, the increasing mortality increased sharply. In the follow-up study by Collette and colleagues, showed also that dead space fraction was associated with mortality in the posterior days of ARDS. Although the most significant feature here is in day one, also day 2, day 3, and day 6 still show some association with mortality. An important point to highlight from this study is that these trials were done with tidal volume around 10 milliliters per kilo of ideal body weight. That could be the source of high dead space fraction because of alveolar overdistension and low cardiac output. However, in the low tidal volume ventilation era, several authors still confirm that this still holds true with a high dead space fraction. It's elevated in non-survivors significantly compared to survivors. It is also associated with an increased risk of death. So, what accounts for this increase in dead space fraction in early ARDS? We don't know precisely, but the two possibilities seems to be the thrombotic or inflammatory injury into the pulmonary capillaries, the microcirculation, and or obstruction of blood flow in the extraalveolar lung circulation, resulting in areas of high ratio of ventilation to perfusion. More than 30 years ago, Zapel and colleagues identified by doing angiograms to study the lung microcirculation areas of vascular obstruction in many patients with ARDS, as is shown here with the arrowheads in both angiograms. These field effects were associated with severity of ARDS, pulmonary hypertension, and poor outcome. This group also did more studies of patients who died from ARDS and found obliteration of a lot of lung capillary with thrombosis, media thickening, and decreased vascular density. Usually, the gold standard for measuring dead space is volumetric capnography, as is depicted here in this slide. And what capnography does is in real time integrates flow with concentration of CO2 as a function of volume, calculated by the Bohr modified equation, where it counts from the PA CO2 and the mixed expired CO2. As is shown here in the left side, is showing a normal capnogram from a normal patient with a VD/VT around 0.37, showing the three phases of the capnogram. Phase 3 represents the gas from the alveoli, and in some ways, looking at this phase is where we get the most meaningful information in terms of just eyeballing and assessing the quality of the slope. As is shown here, the phase 3 is almost flat, as comparing the patient with severe ARDS, in the right side of the slide, where you can see a continuum in the slope of phase 3 on the capnogram. Just by eyeballing, you can tell that there is a great intravenous inhomogeneity, and the VD/VT measured is around 0.75, which is quite a lot. But dead space measurement, however, are not utilized routinely in clinical practice, probably due to the added cost of direct measurement techniques and due to the difficulty in the analysis of the waveform of the volumetric capnogram. In fact, dead space fraction was not included in the Berlin definition. The consensus panel argued that because dead space fraction is challenging to measure, they choose to evaluate middle ventilation standardized to the PaCO2 of 40 as a surrogate instead. However, the addition of the surrogate resulted in the selection of a smaller group of patients and did not improve mortality stratification. So the issue has come up. Could we just estimate dead space fraction rather than measuring it? So to answer this question, Beitler and colleagues evaluated 4 different methods for estimating dead space. The 3 first one, as you can see here in this slide, are estimated using the predicted CO2 production. And one of the formula, the 4th formula, is use VD/VT using respiratory variables. Of the 4 methods tested, only the Harris-Benedict one, which is shown here in the upper left corner, actually had some reasonable relationship to the direct measurement of dead space by volumetric capnography. The Harris-Benedict equation predicted measure VD/VT to within a plus minus 0.10 in 70% of patients. So it's not really terrific when you think about dead space. If dead space, for example, was around 0.65, it could be grown in the direction of 0.55 to 0.75. And if you take all 95% of patients, the standard deviation was 0.20, which is quite a lot. This estimation was less accurate when the PCO2 was less than 30 millimeters of mercury. So if you had to estimate dead space, maybe the Harris-Benedict equation could be the one to use. However, it's not terrific. Further data from the same study shows that compared to all other measurements, estimated measurements, the Harris-Benedict estimate was the best to mirror the actual measured VD-VT association. It was within 7% of measured VD-VT in all quintiles. It did improve predictive validity and for mortality when added into the Berlin definition, so it has some value. Recently, a clinical practical method, and it's called a ventilatory ratio, or VR, has been validated for estimated pulmonary dead space. It can be calculated using routinely measured respiratory variables at bedside. So as you can see here, VR is described by the following formula, where the minute ventilation of VE measured is the minute ventilation that you can measure at bedside with a ventilator. The PaCO2 measure is the millimeters of mercury, is the one you can draw from an arterial blood gas from a patient. And VE predicted is the one minute ventilation multiplied by 100 based on the predicted body weight. And the PaCO2 predicted is set to 37.5 millimeters of mercury, or 5 kilopascals. VR is a unitless number, so and it's around 1 in normal ventilated lungs. The same author recently assessed the ventilatory ratio to physiological dead space, and they observed, as you can see here on the left side of the slide, that it was positively correlated with physiological dead space. And in the right side, when split into ordinal quartiles of VR, VD-VT, physiological dead space in the Y, shown here in the Y-axis, was significantly higher in each sequential VR quartile. Also, they found that a high VR, defined with a cutoff value of more and equal than 2, was significantly higher in those patients with more severe forms of ARDS. However, it's worth to note that these estimates, the VD-VT estimates and the VR, depend on the production of carbon dioxide, which is an important factor for CO2 homeostasis in the critically ill patient, and therefore impacts in any measurement of impermanent ventilation. Moreover, these estimates are validated only in controlled modes of mechanical ventilation. And also, when the patient is off sedation and has some spontaneous efforts, CO2 production changes dramatically. And this is in line with the guidelines that suggest that using less sedation and the practice in the ICU have used less sedation in ventilated patients, and some kind of spontaneous mechanical ventilation is allowed in these patients. So for this purpose, we estimated this estimate dead space fraction in patients with ARDS. We assessed, we did a post-hoc analysis in almost 1,000 of patients with ARDS from the MOS database. It's from 2 mixed ICUs from the Netherlands. And it's important to highlight here that mechanical control modes of mechanical ventilation were not routinely used. So some kind of spontaneous effort was allowed due to a limited use of sedation. We assessed the same formulas as Respiratory and colleagues, and included the ventilatory ratio as well. And the primary outcome here was to assess the predictive accuracy for ICU mortality independent of other physiological variables. What we observed here that we found that at both day 1 and day 2, VD-VT estimates in the VR were significantly higher in non-survivors compared to survivors. And also one of the VD-VT estimates and the VR was associated with mortality with poor outcome and mortality at day 2. This was corrected for Apache 4, PEEP, PEF ratio, driving pressure, and compliance with the respiratory system. As well, day 2, both estimates, the VD, VT, and the VR, when added to the previous model described, improved the model prediction significantly, although limited, but it improved it. Also, this slide and this picture try to depict how estimated dead space contains unique information. So when added dead space for each of the estimates for oxygenation, like a PF, driving pressure, PEEP, and mechanical ventilation, with having a VD-VT or dead space fraction more than 0.68, it increased significantly the mortality. This is done, this VD-VT estimation was used using the Harris-Benedict estimate. So to finish, elevated dead space fraction predicts mortality in early ARDS by finding of pathogenic relevance. Thrombotic and inflammatory injury to lung microcirculation is probably a major early mechanism for lung injury in ARDS. An estimation for impaired ventilation may yield helpful prognostic information not captured by conventional oxygenation indices and respiratory system mechanics in patients with ARDS. And maybe the addition of dead space to a model including oxygenation abnormalities and respiratory mechanics may provide valuable tools for decision making to improve outcome in ARDS. Thank you very much.
Okay, thanks to the speakers and thanks to Dr. Morales. I think we are a little bit late, so there is time for 2 questions. The organizers are telling me there is time for just 2 questions. So we received a question from Fiji for Dr. Cavalcanti. And the question is, would you suggest to titrate PEEP by esophageal pressure as a better way to estimate the right amount of PEEP for the patient?
Well, thank you. Thank you, Tommaso. One of the questions we have, and that we actually need more studies, is regarding the best method to titrate PEEP in ARDS patients. We have several options that consider mechanical variables, for example, best compliance of the respiratory system, or optimizing esophageal pressure, transpulmonary pressure at expiration, that depends on esophageal pressure, and methods based on image. Very recently, we have the EPIVENT2 study conducted by Dr. Beitler and colleagues. This was a second study testing whether a strategy that aimed to keep the PEEP slightly equal or slightly higher than the esophageal pressure. That is, the idea was to keep the transpulmonary pressure at expiration at 0 or slightly positive. And they have tested this strategy in a smaller trial earlier compared to a control group of low PEEP. And there was a suggestion of benefit, but not statistically significant for clinical outcomes. And in the second study, they have repeated that with a larger sample size. I think it was 200 patients. And what they found is that compared to high PEEP, they used in the control group the high PEEP table of combinations of PEEP and FiO2, and in the experimental group they titrated PEEP according to the esophageal pressure, as I explained before, to keep transpulmonary pressure positive or 0 or slightly positive. Unfortunately, they did not find any difference in terms of the primary outcome, which was a combination of mortality and days free from mechanical ventilation, and nor from any other clinical outcome. And it was very interesting that in this study, compared to a simpler method of using a simple table of combinations of PEEP and FiO2, the average PEEP level they obtained was similar in the experimental and control group. The driving pressure, both measured at the airways or the transpulmonary driving pressure, was similar between groups. So unfortunately, this study suggests that this strategy, this more complex strategy of titrating PEEP, considering esophageal pressure, was not useful. So at the moment, probably simpler strategies such as using high PEEP table from the ARDSNet group or other similar would be adequate for patients.
Okay, thank you. The other question is for Professor Guérin, and in particular, I would like to ask you if you suggest we should routinely quantify expiratory flow limitation in all ARDS patients, and if yes, which consequences it would have in our settings of mechanical ventilation?
And thank you for this question. Yes, I think so. I think it's, you know, a fundamental property of the lung and the respiratory system. So we have to assess, because if you have a patient, as I showed, I guess, if you have a patient with airway closure and expiratory flow limitation, so you have to, you know, this is like a threshold. You have to demonstrate and to overwhelm with a PEEP, for instance. And you know, it's probably a way to detect an important contributor to that trauma, and to personalize, you know, the PEEP setting to the patient. It is, you know, another clue for addressing the mechanical ventilation to the intrinsic property of the respiratory system. The issue is how to do that routinely. I think the consequences are clear, you know, in terms of measurement of compliance, driving pressure, and setting PEEP.
Okay, thank you very much. I don't know if we have time for another question. I think the organizers are telling me we should close, but if Pedro would, if Pablo would.
Yes, go ahead, Tommaso. Do the other question.
I can go ahead. Okay, thank you. Sorry. The question for Dr. Morales. The question is, since many ventilators now measure volumetric capnography, do you think that in the future VDVT will be used also to better classify and study ARDS?
I think yes. I think that dead space fraction is a marker of severity, and also could help to differentiate distinguish patients that suffer most from shunt than from dead space, and that can help us at bedside when in improving the therapy with mechanical ventilator at bedside.
Okay, so thank you very much. Thanks to all the speakers for this very nice session, and I think we have to close now. And so thanks again, everybody, and
Thank you.
Back to Pablo.
Thank you.
Thank you.
Thank you very much.
Thank you very much. Bye.
Thank you, guys. Bye-bye.